Boom, the Deputy Incident Manager at the IMST based in DRC. I will now hand over the floor to Prof to start the session. Over to you, Prof.
Good afternoon, Director Margaret. Good morning, colleagues. Good afternoon, good evening, depending on where you are located. It's my pleasure actually to do that press briefing on behalf of our Director General, Dr. Jean Kaseya, who is not able to join, because this has been a very engaging week, as I will present at the global level, the continental level, but also at the national level, where the team have been really pushing hard to make sure that they implement some efficient way, as I will present on responding to the outbreak. And thanks to all you, all the journalists, for being with us for almost a year. I think today it's the 43rd time that we have that interaction, and we don't take it for granted. Thank you, Dr. Margaret. We can put the slide. Okay, next slide. So as I mentioned, and that's the reason why I'm standing for our Director General, it has been a very engaging week at the highest level, where the conference of FFD4 has been happening with the International Conference on Financing for Development, where the shift is happening from aids to investment. So our leaders join together, United, PAO, and other partners, to see how they can push the agenda for sustainable regional health manufacturing. And as you know, Africa CDC has been the champion on the local manufacturing agenda. But also, as we represent the member state, the issue of sovereignty is really one of the pillars, one of the focus of our advocacy, and our DG has been pushing that in those area where the African Center Partnership is also the key point on all the discussion, with a focus on our priorities. We'll be talking about local manufacturing, ensuring that our communities have access to the diagnostics, to the vaccine, to the drugs. As we will see now, we will see in today's presentation for Mpox, we are facing some challenges, which we hope the local manufacturer will be able to help and support in the future. Next slide. In parallel to that conference, the 4P high-level meeting, which is the Pact for Prosperity, People, and the Planet, sorry. So this is critical. We've been talking about the impact of not having peace in the eastern part of DRC, in the South Sudan, where the conflict has been a critical driver to outbreak Mpox, cholera, measles, and so on. We've also highlighted during all our briefing how the global warming, the climate change is affecting. We've mentioned the flooding in DRC, in other countries. And this was a time where we can pause and all the leaders can appreciate how those four focuses are interconnected. So the president, Lorenzo, Ruto, and Macron was available, make themselves available to listen to our challenge and ensure that we have some common solution to move forward and have some solution, local solution to address those challenges. Next slide. Now, going back to some of those challenges, the public health event, we have those four: cholera, Mpox, measles, and dengue that are currently and continuously affecting our continent. As you can see, the number of events per month, now at this point in June, we have already had 136 total events, which is more than half of what we had last year. So it's showing the trend of having more and more of those events, which is challenging, which is actually encouraging to integrate the way we respond to those outbreaks, as I will see through this briefing. And as we have been mentioning, the call of action for our leaders is to integrate the response of cholera into Mpox, because those events will continue while the resources are reducing. Efficiency, efficiency, and efficiency. Next slide. Specifically on the issue of Mpox, we are glad to see that decrease that is continuing in terms of number of suspected cases. We can see almost 10% of reduction, the confirmed case a reduction of 26%, which is quite encouraging. The deaths also are reducing, and we have a case fatality ratio of 0.4. You know, the threshold is 1%. So we are far below the 1%, which is quite encouraging. And then we commend all our member states for the great work they are doing in managing case so that we remain below the 1% of case fatality rate. Now, when you look at the numbers, the suspected case in June, half of the year, we have 97% of the case that we have in 2024. And in terms of confirmed case, we are far beyond just 6 months in 2025. So just to highlight how critical this outbreak has been happening, and it's been happening in this year. But we are glad to see that we have that decline in the confirmed case, as mentioned. Uganda, Sierra Leone, Zambia are accounting for 88% of all the confirmed cases. Next slide. Now, we've been highlighting and keep the emphasis that we are not dealing with one outbreak. We are dealing with 4 outbreaks because we have different clades. And those different clades have different means of transmission, which imply a different way to control and to respond to them. Now we are also seeing that regardless of the clade, as we start, which has been the one that was before endemic in many countries, 1B and 2B, we can see that there is a decrease that is happening regardless of the clade. Next slide. Next slide, please. Now, when we look at the top 4 countries that are reporting 92% of confirmed case, we can see that the decrease in DRC, Sierra Leone, Uganda, and of course Burundi. Burundi that has not been reporting quite a number of cases as the week has been going on. So these 4 countries account for 96.3% of all confirmed cases. And we can also see the slight decrease from 86% that was reported in the week 24. But still, DRC account for 62% of all the confirmed cases since the start of the current epidemic. Just as a reminder that the reason why the IMST is based in Kinshasa is because this country has been the most critical in terms of case since the beginning. Just 1 second, sorry. My office. Sorry, just 1 second. Okay, now we are good to go. Next slide, please. Now in DRC, as we mentioned, we are also seeing that decrease that is happening both in the number of suspected cases, in the number of confirmed cases. We moved from 250 to 194 this week. And the testing coverage remained low despite some up and down. Last week we were at 27%, still mean that we are not getting all those cases who are in the community. The test positivity rate also is 47%, which also telling a bit of the same story. The cases that we see are those coming from the health facility. So the intensification that we've been put in place need to be spread. Most of those is happening in Kinshasa, but it has to happen in all the different provinces. So yes, we are glad to see the consistent decrease, but we need to be very careful because the testing coverage, as is remain low, mean that we are still seeing part of what is happening actually in the community. And this also highlights the challenge that are happening in the surveillance, the bottleneck that we have in sample collection, sample transport, which unfortunately make the alerts, the people who are suspected for Mpox, not all of them, maybe 3 out of 10 will actually be sample and the sample being tested. So the 7 out of 10 might still be in the community without us having the result for the Mpox, and therefore allowing the transmission to continue in the community. So the acceleration of the intensification is happening, and we believe that in the coming weeks, when we'll have that spread of community healthcare workers within the different provinces, we'll be able to have better results to show. Next slide. Now, in Sierra Leone, we are also glad to see the decrease. Last week, we had 282 suspected cases. This week, we are going down to 233. The confirmed cases also are reducing. The deaths also are reducing. So it's quite encouraging. And we are also glad to see that the test positivity, though it's a slight reduction, it's reducing. We were having 89%. Now we are moving to 85%. And the conversation that we have with the team yesterday of Sierra Leone is also encouraging, how they are pushing with the community healthcare worker to ensure that they go beyond the case that are coming to the health facility, because it's in the community that the disease is actually spreading. So this action is showing some result. As you can see, the contact to case ratio is 1 for 23. So for one case, we have 23 contacts, which is beyond the 20 threshold that we've put. It's quite commending for the Sierra Leone leadership in the response to surveillance. But we need to do more. We need to do more in actually catching all the cases in the community, and therefore we'll have a test positivity rate that will decrease. So yes, we are happy to see that the figure are going down, and then also we'll keep on supporting them to ensure that they have the means to continue that community-based surveillance. 200 community healthcare workers are being deployed currently in Sierra Leone by Africa CDC and IMST, and we believe that we'll have some good result again continuing in the next few weeks. Next slide. So surveillance is a key pillar to actually capture the case in the community, but case management is also one of the key points. I mentioned earlier on that the case fatality ratio is under 0.5% at the continental level. And this is thanks to all those training, like the one that has been happening on the optimization of standard supportive care for Mpox improved treatment outcome. So basically, we have colleagues, experts that met in Nairobi. They optimize based on the evidence, based on the expertise, how we can learn from the 10 months of Mpox to improve how we take care of our patient. And this has been used as soon as possible in Sierra Leone to train those 50 healthcare workers on the new and optimized guide for treatment. And this includes the treatment of people living with HIV. We know that they are the most at risk of dying of Mpox, but also those with having other co-infection. Next slide. Next slide. Now, Uganda. Uganda, we can see, we've been seeing that for the last 3 weeks, there is a kind of increase in the number of cases. And the discussion that we have this morning with the team from Uganda, the incident commander deputy, when he was making his presentation, has highlighted that because they've managed to get some support, they've been able to deploy some active tracking in Kampala and in some of the key city of Uganda. That's why they are managing to go beyond the case coming to the hospital to catch them in the community. So we might expect those that increase to carry on for some few weeks, knowing that the surveillance is working hand in hand with the vaccination to ensure that when they find the case in the community, those clusters, they will now go and vaccinate all the contact around, or at least and also all the key population that they are seeing in those communities. The sex workers, the truck driver, and the fishermen. They realize that those are the key driver of the outbreak. So they have a comprehensive approach of link connecting their surveillance, which they are accelerating the community, and also ensure that it moves along with the vaccination that is going on. Next slide. So in terms of case management, if you recall, at some point we were talking about the Entebbe Treatment Center, where we were having almost 120% of bed use, because we were having, instead of having 80 people in the hospital, we were having much more than that. Now we are glad to see that the majority of the center show no new admission this week. This is very encouraging. Once we see what is happening at the treatment center, you see that the surveillance is going in the community is quite reassuring to say we track the patient, but also we have the appropriate environment to take care. Entebbe remained the busiest center, followed by Fort Portal and Rugazi. But in all of them, we are glad to see that there is a decline in the new admission in most of those centers. There has been some capacity strengthening to ensure that the appropriate care is being implemented. And by care, we mean holistic. With the support of the World Food Program, we've been able to provide food to patients, but also to the caretaker, because it's critical to ensure that all environment is well taken care of. There are some few challenges that are still there. The medicines shortage that are happening in some of the units, the fuel shortage affecting ambulance team, notably in Kampala, and those ambulances are key to transport the patient to the treatment center. And the last one, but not the least, the hygiene staffing gap, especially in Entebbe isolation unit. So an emphasis will be put on the case management, but also on the IPC strengthening, so that we have some centers that are up to the standard. Next slide. In Burundi, we keep on showing the reduction of the suspected case and the confirmed case, though we can see we move from 67 to 68, which is more or less the same thing. But the trend is continuing, is reassuring. In week 25, we have 879 contacts that are under active surveillance, yielding to a case-to-contact ratio of 1 out of 12. And you can see that in the beginning, there were around 1 out of 4. One case was having 4 contacts. Now we have 12 contacts for one case. This is quite a good improvement. And next week, the Burundi will come to the IMST to share the experience so that other countries can learn on how they've managed to achieve those great results. Next slide. In Togo, where our team has been visited last week, we are also glad to see that there is a decline in terms of the suspected case, moving from 36 to 26, but also the confirmed case, moving from 12 to 4. The contact listing ratio, we have 15 contacts for one case, which is quite good. We are not yet at the 20, but it's quite encouraging, including that the good contact follow-up is being implemented, which means that the contact are follow-up for the 21 days, and they are ensuring that if there is any suspect, then they will go into the care. Next slide. So as mentioned, the IMST has been visiting Togo last week to really sit down at the highest level with the Minister of Health, then at the level of the NPHI, to assess the Mpox outbreak and the response across the different pillars, but also to identify what are the critical gaps that they are seeing, and of course to strengthening the community engagement and coordination mechanism. So through those assessments, they have agreed on how we as IMST will be able to support through the different partners in the community-based surveillance, but also in the laboratory, where there has been some shortage of some of a reagent that was about to happen, and then we are happy that all is being put in place so that they don't run out of sample. So there have been some clear recommendation and roadmap for improvement, but also strengthening the coordination. Why? Because Togo is a key country in the West Africa. This is the hub for ASCAI, which means quite a number of travelers are going to Togo. It's also a hub because of the market of country all around Ivory Coast, Benin, and all those ones. So it's critical to contain as soon as possible the outbreak in Togo before it's moving to other countries. Next slide. Now, the vaccination. We were happy at some point when we were looking at the number of doses of vaccine that we were able to mobilize. As you can see, 3 million doses that has been mobilized. We can see that 11 countries have the vaccine. 7 out of them are vaccinating, which means that 4 are not, though they have the vaccine, which is a challenge. Most of them because they don't have the operational cost to actually implement the vaccination, and others because they have a lower number of cases as we do speak now. Altogether, 700,000 people have been vaccinated, and countries keep increasing on having the regulatory approval to ensure that the vaccine can be used, though we are still advocating approval to also include children below 12 years of age. Uganda has received 97,000 doses recently, and they have used 96% of the 100,000 doses that they've received before with the targeted vaccination approach that they've been using. So the dose that they receive will be part of the next round, and they will focus on the remaining hotspot to ensure that with those 100,000 doses, they are able to actually contain and also assess the effectiveness of the vaccine in their response. Now comes the challenge. As we do speak now, we have 6 countries that are active and that are requesting to receive some vaccine. But currently, at the global level, there is no dose funded that is available. This is for us a big challenge. This is a crisis in the sense that if on top of the 6 active countries, if any other countries need some vaccine, we won't be able to provide any dose. Next slide. And this is happening, let's say, at the wrong time, really the wrong time, because we can see how the vaccine is being being used in Sierra Leone, for example, in the 3rd round, where they were really focusing on targeting the contact, the high-risk group, which include the sex workers, but also the community care workers and the key population, those living with HIV/AIDS, they really be able to map their hotspot, 16 districts, where they implement a vaccination that was moving hand in hand with the surveillance. So within the last 2 weeks, they've been able to vaccinate 70,000 people. While in other countries, like in DRC, the vaccination with the LC16, the new vaccine that has been donated by Japan, has started. They've planned to start on Monday in 5 L zone in Kinshasa, Equateur, and Chuapa. Next slide. The focus in Sierra Leone, as mentioned, they accelerate their vaccination. They really demonstrate the capacity not only to use the vaccine, but to use them efficiently. Efficiently means targeting the key population. In the beginning, 50% of the people receiving the vaccine were healthcare workers. But as we can see now, gladly so, we can see that the contact represent the highest number of people that have been vaccinated. And what they explained to us yesterday is that they move with the surveillance team. As soon as there is one case, the result is given within 24 hours, and they are able to implement the vaccination within the geographic area around the case. They cannot focus only on the contact because also it's quite difficult to have some of the contact which are due to the sexual transmission, but then at the geographical level, they are able to get those one. The key population, we see 5,000. This also is the result of the partnership that they have with association program of people living with HIV, association of sex workers, so that they move with the communities that are also engaged in the vaccination. And the others are those who are not able to actually mention what is their profile for obvious reason, the stigma that is around the Mpox which is going on. So an additional shipment of 50,000 doses is planned for the country, and that will contribute to the effort that Sierra Leone is putting in place. Next slide. Now from Mpox, we move to cholera. This morning, we were discussing with the national manager of cholera in DRC, highlighting the challenge that they are facing. Next slide. So currently, we have 21 countries in the continent that are affected by cholera. And this represents more than 170,000 cases, more than 3,534 deaths that has been happening up to the 23rd of June. And the key countries that are currently affected are DRC, Sudan, South Sudan, and Angola. Next slide. I'm still in the continental cholera overview. On my side, the slides are not moving.
Can we get the next slide?
So while we are trying to fix, I will continue on the, yes, now it's good, on DRC. So DRC, we are seeing an increased number of cases. And DRC is quite challenging in the sense that the top province used to be the South Kivu. And South Kivu, as now we all know, it's also the province that is affected by the crisis, the military crisis. Also the same province affected by Mpox and also measles. And the challenge of South Kivu is the access. You have an area in the South Kivu, where despite having the medical countermeasure, we are not able to actually be in a position to deliver them to the population. And in those places, the biggest challenge is the access to water, which goes far beyond the medical support, which re-emphasize the need to have that multi-sectoral approach so that we can support on making water available. So the hotspots include the Haut-Katanga, North Kivu, South Kivu that I mentioned, Olomami, Tanganyika, and now Kinshasa. Kinshasa is the capital city. And the biggest challenge with Kinshasa is the high population density, the promiscuity of the population, and the fact that Kinshasa is surrounded by different rivers, the Njili River, the Kalemi River, and those rivers are also where people access some waters, and those are driving the outbreak. So because in some places, the access to drink water, to clean water is not possible, it's keep on driving the outbreak. So this morning we discussed with the colleague from DRC to see how the IMST, as with all the different partners, can leverage on the existing resources that we have gained from Mpox to start supporting them, whether it's on community-based surveillance, IPC, and many others. So they are preparing the vaccination. 11 health zone has been planned to be vaccinated in Kinshasa, but the country has limited funding to support an effective response. So it's also an advocacy to raise more resources for the country. And one critical point that they highlight is on the vaccine, they have to wait the vaccine to be shipped to DRC, while it would have been better to have some stock in the country, knowing that cholera is endemic in these countries. And this brings back our issue of local manufacturing, because being able to manufacture the vaccine in the continent will make them more easily available whenever they are needed. Next slide. Now in Angola, we are also seeing a decrease in the number of cases that has been consistent, with 57% of cases that are happening in hospital. The second phase of vaccine administered has reached 99% of the target, with more than 700,000 doses, and 2 million doses demand has been submitted so that the vaccination can be extended, and therefore moving toward controlling this outbreak. Next slide. In Sudan as well, we keep on seeing that reduction that is continuing, though we are a bit careful looking at the very low vaccination coverage at 6.7, as you can see, knowing that we have those Khartoum and the White Nile represent 82% of the hotspot. We are closely monitoring the situation to ensure that we don't have an explosion of cases that might be circulating in the community. But that is very difficult. As we mentioned many times, without peace, it's very difficult to have health. And the outbreak occur in context of conflict, and that further adds a layer of complexity on the response effort. So the targeted attack on water and power infrastructure really limit the access to clean water to the population and also to the healthcare services, which increase the risk of spread of cholera in the country. So we are glad to see some decline, but we are monitoring cautiously, because with all what's happening with the different drivers, there's a possibility that the cholera can continue to spread within the community. Next slide. So in summary, the Mpox cases are declining. So that is very good news across high-burden countries, DRC, Uganda, and Sierra Leone. But we've seen that there are still some gaps in surveillance. And when the surveillance go to the community, as we see in Uganda and Kampala, but also in Sierra Leone, there are opportunities to catch some new cases. So that community-based surveillance is critical, and these have to move hand in hand with the vaccination. The clade-specific risk, especially in HIV-positive individuals, this is also something that has been highlighted, and the optimization of the SOP for treatment will also bring some new tools to our healthcare workers on managing those patients. The vaccination is progressing, though we are reaching the point where we don't have any dose at the global level to allocate to countries. Six countries are already on the pipeline waiting for vaccine, but they are not available. So this is a big challenge that we have to solve, because this is a global responsibility. Moving to those meetings at the global level where we are moving from aid to investment, it also reminds us that we need to accelerate the local manufacturing agenda so that we avoid those situations where the continent has to rely on other people's solidarity. So the cholera outbreak persists due to the flooding, the conflict that we have been seeing in Sudan, Angola, DRC, and South Sudan. And it requires, as called for action by our head of state and government, an integrated response, which is already happening, as we had a different meeting last week and this week with the countries to see how we can leverage on what we've managed to implement from Mpox to support the response to cholera. With that, I'll be happy to answer some questions with the support of my colleagues who are here in the room, but also in the Addis. Over to you, Director Margaret.
Thank you very much. Let's cross over to the floor. We have Kemo Cham from Mano Reporters. Kemo, you have the floor.
Thank you. I wanted Dr. Boom to speak on the stockouts. I would like to know how specifically it will affect Sierra Leone. Firstly, I need clarification. When you say 0 doses available globally, Is it that the manufactured vaccines are what are not available, or it's the money to procure them that is not available? That is one part of my question. The other one is for you to speak specifically on Sierra Leone and Liberia, how this affects them. Thank you.
Thank you. Let's take the next one before Prof comes in. We have Kadijatu from Afri Radio in Freetown. The question is, given the re-emergence and multi-country spread of Mpox and cholera, what structural or systemic gaps have Africa CDC identified in national surveillance and response systems that need urgent reform across affected Africa Union member states? Back to you, Prof.
Thank you for those very good questions. The first one to Chemo. When we say there is no zero dose available, the manufacturer has the capacity to produce the dose. Two, UNICEF, they also have, let's say, book 500,000 doses to the manufacturer, and they need $33 million to actually buy those doses so that they can be made available to countries. So the challenge that we have currently is the money to buy the vaccine and therefore to be able to send them to the country that are in needs. Countries like Liberia are part of some of the countries that have received some doses, but which are facing other challenge, because we mentioned 11 countries have received vaccine, but 7 are actually vaccinating. Some of those countries are facing the challenge of operational cost, because once you have the vaccine, you need to be able to deliver the vaccine where it's needed. So great effort has been made with Gavi, but at this point, we are actually mobilizing other partners to come and support in countries. We are also pushing, as you know, Africa CDC is pushing for domestic funding. In Sierra Leone, they have not waited to receive extra funds to actually push for the third round of campaign to ensure that they can take advantage of vaccinating almost 70,000 people during those 10 days. So yes, the doses are available at the manufacturer level, but the funding to acquire them, the funding to use them is what is currently missing. For the question of surveillance, I think my colleague, Dr. Cheng, will be happy to answer that one.
So much, Prof. So thank you for the question. I think that's a very, very important question to start with. So in terms of the gaps for surveillance and response that we've been able to identify, looking at it from this outbreak and also past outbreaks that we've been supporting on the continent, I would say the first is the health system resilience. I think we really have seen that after most of the response, we don't have the innate capacity that's left within the systems to be able to support future outbreaks. And one of the things that we're doing, especially within the framework of the IMST, is the legacy that we have incorporated in our plan, which actually speaks to building systems that are resilient, not only for the current outbreak, but also to support. And one of those things are looking at digital surveillance systems. We are trying to actually set up a unified platform whereby we are able to have all the different response pillars speak to each other that can also support our ability to take actions, in real time. The second one is the local capacity. As you would see, most of the countermeasures, medical countermeasures, have been procured outside of the continent. That shows that we don't really have continental capacity to be able to manufacture our own medical countermeasures, including vaccines. And that's also one of the things that we really need to, we are really championing that space with the local vaccine manufacturing agenda, as well as even other diagnostics and all that. So we're setting up these structures that will definitely also speak to the resilience, not only at country level, but also at continental level. The third bit is coordination. As my colleague, Professor Yap, has mentioned, cholera actually requires a multi-sectorial approach in the response and even the surveillance, looking at environmental data, using that environmental data to actually identify potential hotspots. It's what we are not doing. So it's mainly in the human cases that we start being reactive and not proactive by using the information that we have to actually determine how we plan and prepare and also be able to put in the right measures. Again, the coordination across the different sectors speak to the WASH infrastructure. As you know, cholera is has a fecal oral transmission route. Definitely, if you're not able to control it by putting in place very robust water hygiene and sanitation infrastructure, you will just keep being reactive, because definitely we'll have those spillover resurgence coming up. The third is the workforce. And for the coordination bit, we've done quite so well already by bringing in all the